trial. That's why you see number of CVOT trials which have been mushrooming within a short span of time. And along with the risk of coronary artery disease in diabetes, if you see the risk factors, the dyslipidemia accounts for the maximum risk. Like it accounts for 50% of the coronary artery disease, and hypertension to 27%. So in a diabetic, if we control the diabetes, hypertension, dyslipidemia, we can reduce the risk of CAD by major part, around 60 to 70%. So the guidelines recommend moderate intensity statin when no risk factor is present, whereas high intensity statin when more than one risk factor is present. So what is high intensity statin is which daily dose reduces the LDL by more than 50%. Usually atorvastatin is given by 40 to 80 mg, or rosuvastatin 20 to 40 mg. Whereas moderate intensity statin, it reduces the LDL on average by 30 to 49%. Usually atorvastatin is given a dose of 10 to 20 mg and rosuvastatin 5 to 10 mg. So from this slide, we can understand that diabetes can be considered as equal to a cardiovascular disease risk. So what guidelines say about statin and diabetes? So ACC and AHA guidelines say that the presence of diabetes itself is the trigger point for LDL focused intervention. And if you see with the ACC AHA guidelines, they advise a moderate intensity statin for people with diabetes mellitus in the age of 40 to 75 years. While if the diabetic patient has specific risk enhancers, like when they have a long duration of diabetes, or features of nephropathy characterized by albuminuria, or retinopathy, or neuropathy, or if they have ABI less than 0.9, then it advises high intensity statin. And when you come to the ADA recommendations, they classify the patients into less than 40 years and above 40 years. If they have less than 40 years and the ACVD risk is less than 20%, no need of any statin. If the risk is more than more than 20%, they advise high intensity statin. The same way, if it is more than 40 years, this is more important. More than 40 years, even if the ACVD risk score is less than 20%, they advise a moderate dose statin. And if they have a ACVD risk score is more than 20%, they advise high intensity statin. And when you come to the ESC guidelines, they have a goal of LDL less than 100 and for moderate risk people, and less than 70 for high risk people. And if you come to the AAC guidelines, they also have a LDL goal of less than 100 if the patient is high risk, and less than 70 if it is very high risk. So if you combine all the guidelines, almost all the guidelines say that target LDL cholesterol levels for reducing the CVD risk. And when you go to the AHA and ACC ADA guidelines, they advise the physicians to classify the patient's risk level determine the statin therapy. They advise us to classify the patients whether moderate risk or severe risk. If they have a high risk patient, they advise high intensity statin. So what is the efficacy of cholesterol lowering in therapy? Actually, it's a randomized control trial of 14 randomized control trial of statins, and they found that average 5-year treatment period with statin reduces 12% reduction in all-cause mortality, and 19% reduction in coronary mortality, and 23% reduction in MI or CSD death, and 17% reduction in stroke, and 21% reduction in major vascular events, and there is no difference in cancer incidence. So statin therapy can safely reduce 5-year incidence of major coronary events by about, when we have 38 milligram, average of 38 milligram reduction in LDL cholesterol. So what about the statin diabetes mellitus for secondary prevention of CVD? Actually, this is the FOREST trial, which Canadian simvastatin survival study, which has done study around 5,000 patients, where it has randomized the patients. This included the patients who had already an acute coronary syndrome, and they had an average cholesterol of 200 to 300. This is more important. That is the inclusion criteria. The patient should have an ACS already, and they should have a cholesterol of 200 to 300. And they have been randomized into two groups. One group received the placebo, and another group received a simvastatin. And the endpoint is the CSD death or non-fatal MI. If you see that in a diabetic patients, after a follow-up, the statin caused 55% risk reduction, and also in non-diabetic patients, it caused 32% risk reduction. So definitely, we can understand that statin plays a major role, that too in diabetes, in reducing the secondary prevention of coronary events. Whereas next, HPS is a hot productive study. Actually, what is the differences? This also included the patients with the previous MI and other all vascular disease like cerebral vascular disease, peripheral vascular disease, and diabetes. But the inclusion criteria here is the patients were included irrespective of their cholesterol level. The previous study included only patients with elevated cholesterol, whereas this study included patients with normal cholesterol level. And this is the forest plot diagram, which clearly shows that even though the patient's statin is normal, irrespective of the initial cholesterol level, the statin therapy definitely shows a better in case of events like in heart protection study. Further, in the primary endpoint was acute coronary syndrome or any other cardiovascular events. We find that the statin favored better in all groups. So statin and diabetes for primary prevention of CVD. The previous two studies, what we saw is they had previous history of coronary vascular disease. But here, this study is evaluated for the primary prevention in diabetes mellitus. So this included 40 to 75 age of people with no history of CVD, and they had one risk factors like retinopathy, alveolar hypertension, and they gave atorvastatin 10 mg and placebo. And the outcome was acute coronary syndrome, revascularization, and stroke. If you see this, even though the patient did not have any previous incidents of any vascular event, they have been followed up for and found that almost this side, if it goes, it favors the placebo. If it goes this side, favors the atorvastatin group. If you see that almost all patients, whether the patient acute coronary endpoint, primary endpoint, all it favored the statin. So the statins can be used for primary prevention. Actually, this study was terminated even before 1 year because where a maximum number of patients in this group were favoring outcome with atorvastatin, so it was stopped before 1 year itself of the study. So interpretation from the CORD study is no justification is available for having a particular threshold level of LDL cholesterol as a sole arbiter of which patients with type 2 diabetes should receive statins. So statin-induced diabetes. Actually, now we have seen that statin is useful in patients for secondary prevention of CVD, primary prevention of CVD, and many people have a worry that statin cause, many even physicians and the patients worry that whether statin can cause diabetes. So when you see whenever we do any drug, we see the risk versus benefit ratio. For example, if you see with statin, out of every 255 patients you treat for 4 years, one additional patient developed diabetes. Whereas out of the 255 patients you treat for 4 years, 5.4 fewer CHD deaths you get. So when you see, obviously, statins benefits overweigh the risks. And the American ADA has clearly said that the benefits of statins far outweigh the risk. So although statins are linked to diabetes risk, the cardiovascular event rate reduction with statins far outweigh the risk of incident of diabetes patient. And this is the recent study which evaluated the effect of statin on metabolism of glucose metabolism. If you see that the statin has been, this is atorvastatin and rosuvastatin, they have been followed up for a period of 1 year, and it found that the way how much the HbA1c rises from 6.4 to 6.5, it's very minimal, it's only 0.1%. And if you see the glucose level elevation also, the statin rises from 121 to 2, not very significant rise in blood glucose level. So we need not worry about the statin in causing diabetes, and we should prescribe the statin, and we should not avoid statin just because it causes the risk of diabetes. And which is more efficacious and safer statin? If you see, this is the STELLA study which compared all the statins head to head to see the efficacy of the statin. If you see the rosuvastatin, which has the maximum efficacy, which can able to reduce the LDL cholesterol up to 50%, and this is seen in almost all strength like 10, 20, and 40 mg. It is followed by atorvastatin and followed by simvastatin and pravastatin. And if you see, not only in reducing the LDL cholesterol level, rosuvastatin favors other statin in increasing the HDL cholesterol level, which is necessary for diabetes. So when compared to the other statins, rosuvastatin increases the HDL levels better. And if you see with the side effects, like percentage of patients with adverse effect leading to withdrawal of the drug, rosuvastatin it comes only 2.9%. When compared to atorvastatin, it is 3.2%. And the most common side effect which we see is statin-induced hepatitis, where the ALT level will be raised more than 3 times the upper level of normal limit. If you see with the rosuvastatin, it's very minimal. Like for example, even with the highest dose of rosuvastatin 40 mg, the chance of ALT level elevation is very minimal. Whereas when compared to atorvastatin 80 mg, high doses, it causes significant rise in ALT. And when compared to the muscle effects, where we classify by the elevation in creatine kinase more than 10 times the upper level of normal limits, you see again the rosuvastatin higher dose favors when compared to the other all statins. So we say that the rosuvastatin is better than all the available statins in regard to the efficacy and the side effects. So coming to the end, what I said is diabetes is equal to CVD risk? Yes, we have seen. Obviously, diabetes raises the risk of CVD risk by more than two times when compared to the non-diabetes. What guidelines say about statin and diabetes? Actually, it is the guidelines. Guidelines is complicated. So what we use is like usually we take the ADA guidelines. What they say is classify the patients. If the patient is less than 40 years, use the ASCVD score. If the score is more than 20%, use high intensity statin. If it is less, then no need of any statin. If the patient is above 40 years, use the ASCVD score, and if it is more than 20%, use high intensity statin. If they are less than 20%, use moderate intensity statin. But many people say that ASCVD score cannot be applicable. It tends to overestimate the risk in Indians. So what we use is the SKU-RISK 3 score. Actually, this can be usually available in your computer or in the mobile phone. This calculates the ASCVD risk, and this include the ethnicity where you can use an Indian, and it includes all the risk factors. The most important with the Q risk score is it tends to be evaluated, like it is revised once in a year. And what we do in practically is we use the score and calculate. If the risk score is about 20%, actually the risk score comes here. If the risk score is about 20%, we start on high intensity statin. If the risk score is less than 20%, then we classify the diabetic patients into two. Less than 40 years, we advise only lifestyle management. If they are above 40 years, we start on moderate intensity statin. This is the simple way which we use. And statin in diabetes for secondary prevention, obviously it is very useful. And statin in diabetes for primary prevention of CVD, we saw the study, actually statin is very useful in primary prevention, irrespective of the initial cholesterol level. And statin-induced diabetes, obviously the statin overweighs the benefit overweighs the risk. And which is more efficacious and safer statin? It's rosuvastatin, which is more efficacious when compared to the other statin, both in efficacy and the safety. Thank you for your patient listening. Now I request. I think you can post your questions on this to our WhatsApp group or in the group chat. We will discuss the question session in the later. Now I request Anita ma'am to take over and to introduce the chairpersons and start with the session.
A very pleasant evening to one and all. I welcome everyone for this 30th CME Meet. Today, the topic of the day is bursting the myth on COVID-19, which is currently the whole world is talking about. At this outset, I take this opportunity to salute the COVID variants who involved the management of COVID-19 patients in Government Vellore Medical College Hospital and CMC Vellore. We had two eminent personalities at this panel who had concern to come in spite of the busy schedule. First, I'd like to introduce Dr. Seshadri sir, who did his MBBS and MD General Medicine at Madras University and PhD from Sydney University. He is a fellow in Royal College of Physicians in Edinburgh since 1977. He has held various positions on and off in CMC Vellore, as beginning as Senior Research Officer and past post as the Professor and Head of Department of Endocrinology. He is very highly regarded teacher and in the medical community. He is highly decorated with the various medals and awards throughout his academic year. He has also authored more than 100 papers and completed 24 competitive research grants and a reviewer of the 5 medical journals. He had dedicated 25 years of his service to the diabetes, endocrinology, and metabolic disorders. He has a keen interest towards contributing in the prevention of osteoporosis. And he is a life member of various academic and professional bodies, and also like APA and Endocrine Society, and also serves as the editorial board in a TAPI. At present is the medical director at the Thriumalai Mission Hospital, Ranipet. I'm glad to welcome you, sir. And next, Dr. Jacob Johnson, who did his MBBS at Trivandrum Medical College and did his diploma on child health at CMC Vellore and did his MRCP at UK and fellowship in pediatric infectious disease at USA. And here did his PhD in virology in CMC Vellore. He retired from CMC Vellore as a professor and head of clinical virology and microbiology. He taught so many UG and PG students in CMC Vellore. He established a Indian first diagnostic virology lab and conducted pioneering research in the infectious disease. He detected high risk of the post-transfusion hepatitis B in 1972 and established the donor screening at first. And he documented the world first vaccine failure in polio cases in spite of the 3 live vaccine. His model of control became the global polio eradication. And he detected the HIV infection among the sex workers first in India in 1986. And he has published more than 480 scientific papers and guided several MD and PhD students. He is the recipient of multiple awards and medals. Among this, his most prestigious award he received is the B.C. Rai Award for the Eminent Medical Men of the Year in 1990. Very glad to welcome you, sir. I'd like to give an introduction about the COVID-19 by Dr. Jacob Johnson.
Am I audible now?
Yes, sir.
Okay. You want me to start? Hello.
Yes,
Yes,
sir, you
sir.
can start, sir.
Is it audible, sir?
Right. Yes.
Yeah, audible.
Thank you very much for that flattering introduction. President, Secretary, and members of IMA Ranipet and API Vellore, and my colleague, Dr. Seshadri. It's a pleasure to be with you today to talk on a very, shall I say, bad subject, coronavirus epidemic. Let me introduce by saying that this virus is a virus in nature that has been there for millennia in bats. About 5 years ago, a group of investigators, Chinese and Americans, looked at the bat guano, that is feces, in a bat cave in South China, Yunnan province, and detected many viruses, one of which was a coronavirus, which is 95% similar to the SARS coronavirus type 2 that we are talking about. So it is a natural virus, and bat is the natural host of this virus. And it is, bats are territorial. So the bats that roost in Yunnan caves have this virus, and how it escaped into human beings, we are not sure. There are some precedents. You remember in 2002, severe acute respiratory syndrome coronavirus, which is now called type 1, caused the SARS epidemic. Some 8,100 people were infected with some 770 odd deaths. So it was a very slow spreader, but with a very high case fatality rate. Then you would have heard about the Middle Eastern respiratory syndrome coronavirus in the Middle Eastern countries. That is also a bat virus, and bat viruses come to humans usually through an intermediate animal. In the case of SARS, it was palm civets, because of the Chinese style of putting all kinds of animals together in the animal market. So civet cats palm civets got infected. From them, human got infected. Then it spread to Hong Kong, Vietnam, Singapore, and that was how that evolved. The MERS coronavirus is bat to camel to human, but it is not a good spreader between humans, so it does not. It remains as a zoonotic infection, vertebrate to human infection, but not an anthropomorphic infection, which is human to human transmitted infection. The coronavirus that we are dealing with has been renamed from novel coronavirus to SARS coronavirus type 2, because it is closely related to SARS coronavirus type 1. So it's an anthraponosis now. We have examples of zoonosis turning anthraponosis. For example, HIV came from primates in Africa. It became a well-transmitted anthraponosis. Pandemic flu is a zoonosis to start with, then it became anthraponosis. Okay, so now this virus, although it began in, or it's a bat virus, it has now become human virus. In a matter of a few months, it has spread to every country in the world. 215 countries and territories are infected, and it is rapidly increasing as an epidemic in every country. In some countries it has peaked and coming down, but in countries like India, it is pacing towards a peak. So now let me bring some terms that we hear in epidemiology. An anthraponosis or human-to-human transmitted virus, if it should survive in human communities, one infected person should infect at least one other susceptible person. And that is the effective reproduction number. 1:1:1, and so the virus will steadily move on in the community. That is called an endemic state. If this endemic state of R equals 1, effective reproductive rate equals 1, it's endemic. If R becomes more than 1, it becomes an outbreak. If R becomes less than 1, it is declining. And if it continues less than 1 for a very long time, it will disappear from human communities. That is the concept of reproduction number. All human-to-human transmitted infections have, in effect, R equals 1. It just ticks over in communities. In some places, it may be more than 1. In other places, it may be less than 1. But it averages out in time and in space. Then there is a concept of R0, or what Americans call R0, with a capital R and a small 0 subscript. That is called the basic reproduction number. What it means is, if one infected individual exposes himself or others exposed to him or her, and all the people in the group are completely susceptible, all are non-immune, then how many people will the index person infect on the average? That is called R0 or R0. In endemic infections, R0 is a theoretical number because you never come across everybody who is non-immune. Because it is endemic, a few people are already immune, so it will not spread like wildfire. So R0 is a calculated theoretical number in all endemic infectious diseases. But when a new virus comes into human communities, like the 2009 swine flu or HIV or the present coronavirus, all are non-immune. So the initial phase of transmission is guided by R0 because everyone is non-immune. And that R0 number by observation has been calculated as between 2.7 and 3.9. On an average, let's say 3. So each individual who is infected on an average will infect 3 other people. And those 3 other people on an average will infect 3 other people. So there are 9 people now. And they will infect 9 people will infect 3 people each. So 27. So that is how rapidly in a non-immune population infection can grow. Influenza viruses in incubation period is just 1 to 2 days. Therefore, in 1 to 2 days, it will spread. Whereas the coronavirus has an incubation period of 5 to 14 days. Say, let's take 1 week. So the doubling of one infection to 2 or 3, 4 will take 1 week. For influenza, it takes only 2 days. So influenza will spread much faster than the coronavirus. That's why the pandemic influenza takes about 2 to 3 months to go around the world, whereas the pandemic coronavirus has taken 4 to 5 months to go around the world, 3 to 5 months to go around the world. So R0 is an important element in understanding the epidemiology of coronavirus. Now, the risk factor or the context in transmission is social contact. Social contact is the determinant of transmission, the risk factor of infection. But social contact is not the mode of transmission. The mode of transmission is droplets of oral and nasal fluids that comes out when you breathe out. Nasal exhaled air already contains tiny droplets. When you speak, larger droplets come out of your mouth. If you cough and sneeze, huge number of droplets come out. And these droplets are of different sizes, but even when the droplets are tiny, and even if they are in aerosol form, you could get infected. So the risk of infection is determined by the nearness to the infected person. On the average, at about 6 feet to 7 feet, the infection rate drops dramatically, but it does not go to zero. So that is the risk factor or determinant is social contact, but the route of transmission or the mode of transmission is droplets and to a certain extent aerosol that is inhaled by the uninfected person. In the case of SARS, only sick people could transmit the SARS virus. That's because the receptors of SARS virus was confined to the lungs, whereas the receptors of influenza virus is in the upper respiratory tract. The receptors of ACE2 receptors of the SARS coronavirus type 2 are both in the upper respiratory tract and in the lungs. And in all many body tissues. Therefore, unlike influenza, the SARS coronavirus will spread from upper respiratory tract to lungs because there are receptors, and then break the mucosal barrier and get into the lymphatic and blood circulation and go in almost every organ or tissue in the body. So that is the reason why the virus is more virulent and causes much morbidity. There is also transmission by fomite. That is virus deposited on objects and surfaces, and somebody touch that surface for a short period of time. We don't know exactly how long, but if you pick it up and then we have a tendency to rub our eyes with the finger, and you inoculate the eye mucosa, and then through the lacrimal duct, it reaches the nose, and then you get infected. You get a mild conjunctivitis, and then you get infected in the respiratory tract. You have then the infection extending to the lung, and you have the risk of viral entry into the body tissues. Why is it important that the risk factor is social contact, but the mode of transmission is droplets? Because when you look at reducing the probability of transmission and infection, you can either remove the risk factor, social contact. So therefore, you say social distancing is a way of reducing transmission. What is social distancing? No two people should come within 6 feet of each other. And the most drastic way of social distancing is the lockdown. Now, lockdown, as you know, has many repercussions in society. And it's not a it's not an ideal solution. A better solution to reduce transmission is to reduce the transmissibility of droplets by the infected person wearing mask. Therefore, the droplets are blocked, just like the surgeon wears a surgical mask, and when he speaks, his droplets do not fall into the surgical field of open wound. So that is the logic behind wearing masks by infected people. Many of them are, they don't even know they're infected, they are asymptomatically infected. If the asymptomatically infected person should wear masks, everybody should wear masks. Then only the asymptomatically infected person also would wear masks. If the uninfected person wears a mask, his probability of inhaling any escaped small droplets into the atmosphere, it will be drastically cut by the uninfected person wearing a mask. That is why universal mask wearing is a very elegant, simple way of reducing the probability of transmission very, very effectively. And it is even better than lockdown or stopping any social contact. The social contact is necessary for emotional health and for economic activities. So the Eastern cultures and the Western cultures have different approach to mask wearing. The Western cultures are very individualistic culture. As everybody knows, from the time you are about 18 or 19 or 20, you're independent. You get out of your home, you don't live with the parents anymore. You have to earn your own living. So you have to learn everything to do by yourself. Whereas Eastern cultures are a little more socio-centric. We help each other. We are not totally independent. We are not totally autonomous. We depend on other people for many, many things. In such cultures, mask wearing is not taboo, whereas in the Western cultures, mask wearing is almost taboo. I'm known by my face. Why should I hide my face? So that is the reason why mask wearing became appreciated by WHO, CDC, NIH, and many Western countries quite late. Today, every scientific paper on mask wearing tells us that it is the most simplest and most elegant way of reducing transmission. US states that popularized mask wearing have far less incidence of infection than US states where mask wearing was not very popular. Okay, so let me also add that the dose of inoculum, that is how much virus do you inhale, will determine how severe your infection is likely to be. If you have just 1 or 2 particles take root in the nasal mucosa, then your further sequence of events in the body are slow, immune responses catch up, therefore you tend to have a milder infection disease than if you are a COVID ward attender, nurse, doctor, and you are exposed to many, many viral particles in the atmosphere, and your inoculum dose could be very high unless you wear proper personal protective equipment. If there's any lapse, the dose that the medical person, nurse or attender will get is far larger than a casual contact that you go to a shop, somebody was infected, you came near that person, you didn't say hello to each other, but you stood next to him. If you wear a mask, your risk is virtually zero. If you don't wear a mask, you have some risk. Finally, let me tell you something about RT-PCR. In detecting infection, we culture the agent, bacteria, viruses, or you look for the antigen of bacteria or viruses, or you look for the gene segments of the bacteria or virus. The gene segments, detecting gene segments is highly sensitive and highly specific if you do the sampling correct. What is PCR? Polymerase chain reaction. One molecule is made into two, then you peel off the second molecule, and on the template of the first one, you make another one, peel it off, another one, peel it off, and so rapidly, in a matter of 1 hour, you could have hundreds of thousands of replica of the original gene segment if you do the test right. That's called the chain reaction based on a polymerase. Now, the virus requires polymerase for replication. It's a single-stranded RNA virus. That is why polymerase inhibitors have a role in treatment, which probably Dr. Seshadri will touch upon. The virus genome is RNA. RNA is usually single-stranded. But for the success of the chain reaction, you need double-stranded gene material. And the classical double-stranded gene material is DNA. So you have to make the RNA as a template. Based on it, you have to make DNA, and that is the reverse transcripted RNA to DNA, and you first make DNA, and then you replicate that by peeling off one of the strands, then the amino acid pile up, second strand, peel it off, third strand, peel it off. So converting the RNA to a DNA template is the reverse transcription process, RT. And then polymerase chain reaction, that is the RT-PCR. Okay, that is the current lab testing. Antibodies, very, very briefly, you know, IgM antibody comes up early and it remains for a short period of time. Then the body makes IgG antibody. IgG antibody lasts for a longer time. And in some infections, cell-mediated immunity, CMI, that is the T-cell mediated immunity, is stronger than the antibody-mediated immunity. So there's a balance between the two. So in some infections, one is more predominant. In some infections, the other is more predominant. In the case of coronavirus, it looks like CMI is more predominant than antibody. Therefore, antibody tests have to be taken with caution in relying on antibody tests for any diagnostic purposes. We have to wait for a little more time before investigators come up with firm answers of the antibody test value. Okay, that is basically an introduction to the virus, epidemiology, and lab tests. Back to you, Manikandan.
Yeah, sir. Thank you. It was a very good presentation. Thank you, sir. I will ask now Seshadri, sir, to speak on the clinical criteria. Sir, I will focus the slide, sir. Seshadri, sir, are you available? Sheshadri, sir?
Yeah, is available. Yes.
Yeah, sir. Yeah,
Can you hear me?
Yeah, sir.
Can you hear me?
Yes, sir.
I will share the slide, sir.
Yeah. Before you put on the slide, I just want to say thanks a lot for API Vellore and IMA Ranipet for having us with you for this discussion. I would like to specially thank Professor Jacob John, who has been my mentor for so many years. When I joined CMC, as a postgraduate student in internal medicine, Professor Jacob John was somebody we all really looked up to, both for his clinical skills and for his meticulous attention to detail in the laboratory. A phenomenal person, a person who has inspired many scholars, many PhD students, and his students are spread far and wide. And I'm probably one of the few who still hangs around in Vellore. And I'm basically by training a physician and endocrinologist. But when I was working in the secondary level hospital, Thriumalai Mission Hospital, I was confronted with this problem of coronavirus epidemic that was due to arrive in India. And I still remember Dr. Manigandan walking up to me with our index patient, a 55-year-old lady who had traveled to Bangalore. This was around the third week of March. This lady came back. She was breathless. She was not a diabetic. And the chest X-ray showed bilateral infiltrates and her saturation was 85. So he said, okay, it may be community-acquired pneumonia. Did a count, and the WBC count showed a normal white cell count with lymphocytes less than 20%. That rang a bell. So we said this could be our first index case of SARS-CoV-2 infection. We did not have a PCR test, but we still had to treat this lady. And I had read up about this problem. And therefore, I told Manigandan we will start on hydroxychloroquine, which was readily available, and azithromycin. And we said we will monitor you over the phone at home. And we told her to isolate herself at home. So precisely what she did. And we kept a follow-up on her and her family. And over the next 7 days, the next 2 days, she got much better. And by 7 days, she was all right. And the family members were okay. That was the incident that stimulated my interest in this infection. So I said, okay, we are going to see more of these. And therefore, we should have our own protocol for Thriumalai Mission Hospital because we are responsible for about 35,000 families around. So I sat down and wrote up a protocol, looked at the clinical features, and then said, let us use some clinical criteria for diagnosis and use them. PCR will come much later, but then patients have started arriving. So you have to act. So I wrote up these criteria, but I sent it to Professor Jacob John and asked his advice. So he told me, yes, this is very important because India is a country where the test is not going to penetrate into the rural areas. And there are many parts of the world where the test is not going to be available for clinical use. So he said, it will be a good thing if you can write this up. That was the story behind an endocrinologist like me taking on an infectious epidemic. Okay, can I have the first slide?
Yes, sure.
So Dr. Jacob John and I went back and forth on these clinical criteria and refined it and refined it and refined it. And he was very largely instrumental in my writing up this paper. Okay, can I have the next slide?
Yes, sir.
Now, this is what we originally proposed after a period of about 4 weeks of criteria going back and forth between us. We said there must be fever. Fever was the most common symptom of the disease, and fever of more than 3 days duration, so that other short febrile illnesses do not sort of cause a problem with differential diagnosis. And the fever should be without any obvious localizing symptoms such as dysuria, skin or soft tissue infection. That is mandatory. You have to have that. Major criteria, dry cough, sudden recent onset of loss of smell and taste. This was becoming apparent in many countries as a unique and distinctive symptom. You need to, of course, exclude anosmia due to nasal block and sinusitis, and physical findings of crepitations on chest auscultation in the absence of a productive cough. So that usually indicates interstitial involvement in the lung. And a chest X-ray showing peripheral patchy infiltrate, not a lobar pneumonia or cavitating lesion. Lobar pneumonia is pneumococcus, and cavitating lesion, acute, it could be staphylococcal pneumonia, Klebsiella pneumonia, or it could be tuberculosis if it's chronic. And a respiratory rate of more than 25 per minute, indicating that there is a difficulty in oxygenation. Tachypnea is the first response to oxygenation. And we included minor criteria: diarrhea, severe headache, body aches, fatigue and lassitude, normal or low normal total WBC count, and lymphopenia, like in our index patient in Thriumalai Mission Hospital. Next slide. The epidemiologic setting at that time was very important because where the patient has traveled, where he comes from, would determine the probability of his having this coronavirus infection. So travel within the past 4 weeks to or from any other country, and we added cautiously a big crowded city in the country. That's becoming true now. We are getting cases from Chennai. Visit within the last 4 weeks to a crowded place such as bus stand, railway station, movie theater, airport, without a mask. Okay, that's a big risk. And contact with a proven case of COVID-19 at home or at workplace. So we defined the epidemiologic setting. And we also said, how do we use the criteria? You must have the mandatory criterion of fever, presence of one epidemiological setting out of the 3 mentioned, along with 2 major criteria, or 1 major criterion and 2 minor criteria. It's a bit like Jones criteria for rheumatic fever, which you all been taught as undergraduate students, similar. But even in the absence of the epidemiological setting, the presence of 3 major criteria and 2 minor criteria, or 2 major and 3 minor criteria, would be sufficient to come to a clinical diagnosis. Please remember, in infectious disease, defining the clinical diagnosis is of paramount importance. If the one thing that this epidemic has suffered from right from the beginning, it is lack of a clear-cut case definition. Whereas in fact, this disease is so unique and has so many unique distinctive features that it is possible for a clinician to drop these clinical criteria for diagnosis. Well, we sent this for publication and it got published after a lapse of 4 weeks after intensive review. Next slide. Now, times have changed from the time we wrote this up. In the last week of April, it was published. From that time, it has changed. And therefore, we have had to revise the criteria. And we had to revise the criteria in the light of current knowledge and in the light of changes in the epidemiology. Currently, within India, the disease is widespread and spreads from person to person. It is not getting imported. It is getting transmitted from person to person within India, from town to city, city to town, city to village. So there is a widespread community transmission, which Professor Jacob John alluded to. And so epidemiological setting is no longer relevant. You and I can get it, right? The major criteria we grouped into 3, Group A, Group B, and Group C. Group A is fever for more than 3 days, dry cough, sudden onset of loss of smell or loss of taste. Group B is mainly respiratory, crepitations on chest auscultation, respiratory rate more than 25 per minute, and use oxygen saturation by pulse oximeter, less than 94. It's very easily available. And Group C is imaging criteria, CT scan or chest X-ray showing patchy peripheral infiltrate or bilateral ground glass appearance without consolidation or cavity lesion like before. Okay. And minor criteria, we expanded the list by adding conjunctival irritation, which Dr. Jacob John alluded to, with a pink eye with or without secretions. And skin lesions have become evident as one of the features of the disease. They can be maculopapular, erythematous, urticarial, or vesicular, but they are non-pruritic. Because the WBC count still is an important minor criterion. Now, we said for a diagnosis, you need to have 3 major criteria, 1 each from Group A, B, and C, okay? Or 2 major criteria from Group A, 1 from Group B, and at least 2 minor criteria. This is because CT scan may not be widely available in rural India, and in some places even a chest X-ray may not be available. But even those situations, our doctors should be able to make a clinical diagnosis. So in the absence of the radiological criteria with the group C, the number of criteria, major and minor, have to be greater for you to make a diagnosis of COVID. COVID is coronavirus disease caused by SARS-CoV-2 infection. Just a clarification, as Professor Jacob John said, about 40% of patients who pick up this coronavirus infection are asymptomatic. They don't show any symptoms. Another 30-35% have very minor symptoms. Okay, that leaves behind only a small group of people with sufficient symptoms that will bring them to a physician. And it is that at that point in time where these criteria are going to be helpful for coming to a diagnosis. Next slide. Now, you not only need criteria for diagnosing, but you also need to assess severity. And this was drawn up by Professor Jacob John in his inimitable and very simple way, which is adapted to the rural setting. If you are able to do your daily routine without discomfort, and your oxygen saturation is above 90 on room air, and lung imaging shows only patchy peripheral infiltrate without diffuse disease, ground glass appearance, then the illness is mild. If the patient is feeling too ill to do his daily routine, requires assistance, but other clinical radiological features are as above. So here is the level of disability that has crept into him. So that indicates moderate disease. If the patient has a saturation less than 90 on room air, respiratory rate goes up to more than 30, and if chest imaging shows diffuse disease, ground glass appearance, the illness is severe. Very simple. It is eminently doable in any rural setting. So that is what this is meant for. It's meant for use all over the country, particularly now that the rural wave of the epidemic is going to come, and we are not very sure how much time it will take if you do a PCR in a remote village for the result to come. Before the result comes, you need to be able to manage the patient. Next. Next slide.
Excellent.
Now, we added a note on elderly and those with comorbidities for a very precise reason. Because these people, the disease may be full-blown, or it may not fulfill the diagnostic criteria which were described above. Because these people's immune system may not be as robust as somebody who is younger. Often these elderly and vulnerable people have only subtle clinical features. They may have low-grade fever, but they may become sick. They may be delirious. They may be drowsy. They may find it difficult to get up and move around. Okay, these are warning symptoms in the elderly and vulnerable. And any elderly person showing these features should have a pulse oximetry and chest imaging done immediately. And if they show the oximetry criterion and the imaging criterion for COVID, they have severe COVID. They have severe COVID and they need to be admitted and managed. They cannot be managed in the home setting. Okay. So this is a modification that was added for elderly and those with comorbidities. These criteria are so simple that even a nurse, a trained nurse, should be able to use these clinical criteria to make a clinical diagnosis. Very often in rural India, the person who is more readily available than a doctor will be a nurse. Next slide. Okay, I think I will stop there, and we will take questions and answers. I think we said this will be an interactive session, and we will take questions and answers. And to do that, I've just spoken about the criteria. So yeah, we can start with the first question.
I request Dr. Anita ma'am to start with the questions.
Yes, sir. Thanks, sir, for a clear and elaborate discussion about the introduction and then the diagnostic criteria. Let me ask about the question. First is, from a senior physician, a 65-year-old practicing physician with the comorbidity, even after advised following precautions like proper hand wash, mask with a 5 feet distance by the patient at the clinic, and a doctor with a triple layer mask and facial unsterile gloves, scrub suit. But even after that, is afraid of transmission of virus. He's asking that shall I practice with more precaution or temporarily stop the practice? If so, till when?
Okay. Can I request Professor Jacob John for a comment?
Like next question or
Yeah. No, Professor Jacob John. Can you request him to comment about this? This is a very nice question. And
I'm a virologist, not a physician, but yet, sure.
no, sir.
Make a comment.
Okay, just a comment, yeah.
Knowing that it is respiratory transmitted, you should be able to protect yourself quite well if you don't allow more than one patient in the room next to you. He wears a mask and the doctor wears a mask plus a face covering visor, and after any touch, the doctor cleans his hands well. He is covered with some apron so that you can remove that later on. And if you see patients one by one with hand cleansing in between, I think the risk of any transmission from an asymptomatically infected person should be reduced to very, very low. Is it going to be zero? It is difficult for me to say. The catch here is the 65-year age. I think physicians, even at 65, could practice full PPE and handle one patient at a time, provided the patient does not cough and sneeze in the room, in which case the doctor will have to run away from the room for a few minutes because the virus will be floating around. But if the doctor is wearing an N95 mask and goggles and a visor, I think you can boldly continue practicing.
Yeah, I think very, very nicely put across. I think what Professor Jacob John is saying is you are 65 years old and you have comorbidity. You are exposing yourself to a risk. You need to understand that. Now, what exactly is this risk? Getting some definition of that might help you to make a decision. At the age of 65 with comorbidity, if you have the misfortune to get the virus infection, then you can develop serious COVID pneumonia. And remember, even if you develop a serious COVID pneumonia, you have a chance of getting out of it of 95%. Okay. So there only a 5 to 7% risk of you are becoming very sick, going on ventilator and so on. Okay. So you may actually get a COVID infection. It may not be as devastating because of the precautions you have taken. If you take adequate precautions, like Professor Jacob John explained, the inoculum size, if it happens at all, will be small. Correct? So if the inoculum is small, you may get away with a minor or moderate degree of infection. Right? Now, if you want to eliminate risk altogether, you can do what I do, which is telemedicine. All right? Now, I see patients only on telemedicine for a reason, because I don't want to expose myself to risk. The patients I handle, diabetes, hypertension, and so on, can be handled quite well on a telemedicine platform. Okay? And if they have any emergencies, I know I can depend upon my younger colleagues to take care of them. I refer them to the hospital and they'll take care of them. So in the interest of your personal safety, if it is possible for you, you can go on to a telemedicine platform. N95 mask is an excellent idea. And I think That will actually be a very good thing to go for if you want to continue to practice. And having patients one by one, very useful. See them by appointment, and don't have too many patients hanging around in front of your room. Okay, these are small things that will go a long way to streamline your practice and ensure your safety. Can we go on to the next slide?
Hi. Yes, thanks. Next, for already you answered this question. For physician, a AAA mask or N95 mask, which is preferable. Answer. So we move on to the next question. Which is preferable for physician while seeing a patient, a body cover, linen gown, or non-woven full cover?
For a, yeah, see, if you're a, it depends on what kind of physician you are and what kind of patients you see. If you are a respiratory physician, or if your practice consists of a large number of patients who come with upper and lower respiratory problems, then the precautions mentioned above, face cover, head cover, goggles, and N95 mask. And if you want to use a gown because you don't want droplets settling on your clothes, you can just use a surgical gown, okay? And at the end of the day, you can take it out and put it out for wash, and that should be quite okay, so long as it's adequately washed with soap and water. Now, should you wear a pair of disposable gloves? That might be an idea, but far safer to wash your hands with soap and water in between patients, all right? But if you are in a situation where you have to frequently examine patients with your hand, and you think that this is going to be a nuisance, washing hands, then anyway, if you are wearing gloves also, you have to wash your hands between patients because you don't want to transmit disease from one patient to the other. So you can look at that option. Wear a pair of unsterile gloves, wash your hands with the gloves on with soap and water between patients. Okay?
Thanks. Next. At clinic and hospital, which is preferable to prevent the viral spread? A window AC, split AC, or no AC with the open window? Can you comment on this, sir?
Professor Jacob John, would you like to comment on that?
Yes.
Yeah.
You know, this virus is in the air as droplets and aerosol. So a well-ventilated atmosphere will markedly dilute the virus particles and will reduce the risk to virtually zero if you are a well-ventilated, if your surroundings are well-ventilated. All ACs, if they are recirculating room air, which most ACs do have that recirculation, most car ACs also have, there you are concentrating the virus and allowing it to keep on floating in the air. Not a good idea. So in any crowded place, particularly where there are a number of people, that is very bad for aircraft also, because aircraft air is recirculated. About 60% of the air that comes back into the aircraft is recirculated air, because outside is very cold and you don't have to heat up the air. Therefore, that is the way it's done. Yes, it's a bad idea. If you have an air conditioner, it's not a good idea at all. Even wards, preferably open air or well ventilated, are preferred. Remember olden days, TB wards had to be well ventilated, and the same thing applies to coronavirus also. However, how can a building architecturally made only for AC manage is something that is mind-boggling. Seshadri?
Yeah, I think I still remember the old photographs of Aunt Ida Scudder, who started CMC Hospital, going to peripheral clinics, and the clinics used to be conducted under trees. Now, that's a fantastic idea. Okay, the more the open air, the better you are. Now, you can't go back to that. So the best thing you can do is keep all the windows and even the door partially open. Make sure that the nurse does not allow another patient in when one patient is inside. Number three, one thing you could do is to have a fan behind you, a pedestal fan behind you. Okay, that will facilitate air movement. Okay, away from you and away from the patient towards the door. Only thing is, you must make sure that there is nobody hanging around outside the door. Okay, if you make sure, that might be a useful idea. All right. Now, AC rooms are not a good idea. No, recirculating air is not a good idea, because you are going to see a number of patients and you are going to take a concentrated aerosol into your lung. Not a good idea. Can we go on to the next question?
Thank you, sir. At the end, there is no AC. We are going back to old age.
Yes, no AC.
How about handling and going through patient files? Is it safe? Can it spread by handling the patient files?
I think hand cleansing comes in here. See, when you are handling a patient file, what is it that you are afraid of?
Sir?
What is the thing that you are afraid of when you are handling a patient file? The patient may have coughed or sneezed, and a few viral particles would have fallen on top of the file, and it may survive on the surface for some time. You may actually touch it, and then you may accidentally touch your face or not. Now, if the patient is wearing a mask, and if you are wearing an N95 mask, then the chance of this happening is remote. But you do need to cleanse your hand after each patient. I think that should be sufficient. You can handle patient files. I don't think there is an issue with that.
Like many asymptomatic cases, visit clinic for other complaints, while accidental screening found to be COVID positive. So what can be done? Is it time to keep our eyes wide open or time to keep our clinic open? Sir, comment on this.
Now, there is no way in the world that you are going to be able to diagnose an asymptomatic patient with SARS-CoV-2 infection short of doing RT-PCR test on everybody. That is just not feasible. Okay, that is why the universal masking is a brilliant idea. And the person who actually wrote first about it was Professor Jacob Jordan. I hope you are all aware of that. He was the first one to write to the Hindu paper saying, for preventing spread of the disease, universal mask is essential, and that is the thing that will flatten the epidemic curve. Many countries resisted, but they've all fallen in line. And the countries which did not follow this are paying the price for it. So, if you are wearing a mask, patient is wearing a mask, well, you are protected even if the patient is asymptomatic. So that's the beauty of universal masking. Dr. Jacob John often compares this to, say, preventing HIV infection, all right? If the male wears a condom and the female wears a female condom, then there is no disease transmission. Same way in COVID-19, if everybody wears a mask, the risk is markedly reduced. Okay? So that's what you need to do. Personal protective measures to prevent getting infected from asymptomatic. So don't allow any patient to come into your room without a mask. In fact, into the hospital, the patient will be wearing a mask when he comes to the hospital. If he is not, somebody at the portico should make sure that he wears the mask before he enters the hospital. You must have some thermal screening done there. If the patient is febrile, then you have to fast track these patients, see them quickly, and send them for testing if required. Okay, so all these are very important. Okay, having a separate area for febrile patients, fast tracking febrile patients, and masking everybody, symptomatic, asymptomatic, before they enter the hospital into the doctor's room. These are very vital. All right. Can you go on to the next one? Okay, validity of HCQ in prophylaxis therapeutic use. Azithromycin. Why do some young patients without comorbidity succumb to the disease? Three questions. Okay, right. Now, Dr. Mani, can I have my next slide? I was about to give up on hydroxychloroquine because a number of studies control clinical trials saying that is not effective. The drug has been withdrawn from the recovery trial in the UK. The drug has been withdrawn from the solidarity trial conducted by the WHO. But today morning, when I was looking at this paper, my interest in the drug was rekindled. This is a single center study from the United States, Henry Ford Hospital. There were 4 regimens that they used. It's only a descriptive study. But you look at that bottom line there. Now, that is patients who received no hydroxychloroquine, no azithromycin. That is the in-hospital survival rate. They have the least survival rate. Now, the top line, the green line there, that represents the survival rate of people who received hydroxychloroquine and azithromycin. Okay. Now, azithromycin alone was very similar to no drug. Hydroxychloroquine alone was better than these two. Message: what are the extent of reduction in mortality? Mortality reduction was 65% with hydroxychloroquine alone and 71% with the combination. Now, this is only a descriptive study. It's not a case control study. But look at this line here. They used the drug within 1 day of hospital admission. Unlike the other studies, which have actually found no benefit from hydroxychloroquine, where perhaps the drug was used late. In Henry Ford Hospital, within 1 day of admission to the hospital, the patient had received hydroxychloroquine if he was in that regimen group. And within 1.1 days, if he was given hydroxychloroquine and azithromycin. So the timing of administration of the drug seems to be important. Can I have the next slide? Now they did what they call propensity match. Propensity match. That is, you look at all the risk factors for these patients and match them. There were 190 subjects who were equally matched in terms of all the risk factors. And this is what happened to people who were not given hydroxychloroquine. This is what happened to those who were given hydroxychloroquine. Survival was 50% better. Mortality came down by 50%. So this is a study that is going to redefine what people are going to do in terms of treatment. Okay. So these people have now called for another randomized control trial. Of all the drug regimens that have been used, this seems to have been the best. These workers also used steroids in the treatment. As you all know, in the solidarity trial, they found steroids are helpful given for a short period of time. Henry Ford Hospital used steroids, but steroids were used for everybody who was sick. So the effect of hydroxychloroquine plus minus azithromycin was over and above the effect of corticosteroids. Okay, that's what you need to understand. So you are going to see more of this drug now. Now, in terms of prophylaxis, I think the only study that we have available is the ICMR study. And the ICMR study where doctors and healthcare workers took the drug regularly beyond 6 doses, there was a significant reduction in acquiring the infection, and this was over and above the effect of PPE. PPE is very helpful, but over and above PPE, hydroxychloroquine did show a significant benefit. Now that study itself could have been done better, but that's all we have now. So for the present time, I think what we are doing in India, it seems to be correct, which is hydroxychloroquine at diagnosis for patients with COVID-19 and hydroxychloroquine for prophylaxis of healthcare workers and contacts of individuals with infection. Okay, if one family member is infected, other family members. Of course, you have to follow all precautions. Not on other drugs. In diabetics, if you are giving the drug, you have to reduce the dose. All that we have mentioned in our paper. You need to follow all that, but use cautiously. But I think there is enough to continue to use this. Now, regarding young people who come and die with COVID, I think there's a question about that. I think that happens not only in India, but in every country. That is related to a very high inoculum process. Can I invite a comment from you? Young people getting COVID and succumbing to that. Is it the inoculum effect?
Next, we move on to the next question.
Okay. Okay. You want to go on to the next question?
As the syndromic approach being field tested and found to be strain specific, is it worthwhile to prescribe all the diabetic HCQ along with the adjustments of other OHA for the pituitary prophylaxis in use, since how it is being recommended only for healthcare workers and close contacts?
I would not recommend giving this prophylaxis to all diabetics for a simple reason, because the level of exposure is important. Now, people are all aware of this disease. People know that diabetics and elderly are vulnerable. So diabetics tend to seclude themselves in their homes and try to distance themselves from others, and they are more meticulous with precautions than non-diabetics. Okay. Under those circumstances, giving all diabetics hydroxychloroquine may be overkill. But if it is a diabetic physician, for instance, yes. Or a healthcare worker with diabetes, yes. Or if a diabetic family member, younger family member develops a COVID problem, no contraindication in the older person, yes. So there are specific situations in diabetes where the drug may be added on, provided you reduce the dose of the drugs he is taking for diabetes by about 30% and readjust the dose of anti-diabetic medication, because HCQ can cause hypoglycemia. All right.
Right.
Ma'am, are you available? Anita ma'am?
Yeah. I think I've got the, okay. No, I've got the question here.
Yeah.
As a syndromic, oh, okay. The next question that have been asked, the list that have been given to us, has a syndromic approach been field tested and to be sensitive and specific? It's a very interesting and important question. Currently, it is being tested out, field tested in CMCH. CMC hospital did not have enough number of patients to test it out earlier. Only now they are getting enough numbers. So the Department of Medicine in CMC is now testing it out. Now, remember, we wanted to do it in TMH, but government was handling every patient with COVID, so we had to refer out every patient, and so we really could not test it out in TMH. Okay. And now we have shared these clinical criteria as widely as we could through to secondary level hospitals, mission hospitals, through API, through all fora. We have shared this for clinicians to use. Okay, next question is about modifications of syndromic approach. Yeah. Okay. The next question was about modification of the syndromic approach you proposed. I've already presented that, the revised criteria. Revised criteria have just been put up, and I can circulate it to you. Right? Role of vitamin C, zinc, and ivermectin. Now, one of the problems.
Vitamin C and zinc.
Yeah, vitamin C, zinc, and ivermectin for improving immunity. Now, of the three that you mentioned, zinc is interesting. No, let us leave vitamin C and ivermectin out. Let us focus on zinc. Now, there is in vitro evidence that chloroquine is a zinc ionophore. That means it allows transport of zinc from the extracellular fluid to within the cell. And in vitro studies with the SARS-1 virus, they found that this transport of zinc into the cell was very important for inhibiting viral replication. This happened with the SARS-1 virus, right? Now you are down to SARS-CoV-2. It may work the same way, we do not know. But since hydroxychloroquine does work, you do not want the efficacy of the drug to be compromised by not having enough zinc. So a zinc supplement may be in order. But vitamin C, ivermectin, I would probably not use them because it becomes too many drugs. You get what I mean? And when you give too many drugs, patients often forget to take the important one. All right, I would just stick to just HCQ and zinc. The next question is, why do some patients, the antibodies that get rid of the disease, that is in most, while in the same antibody
why do
kill
some
the
patients some kills the patient with the cytokine storm, especially when the viral load has become negligible?
Okay. How do you know that the viral load has become negligible? Actually, if you look at studies that have looked at tracheobronchial aspirate in ventilated patients, in fact, there are a lot of virus there. And people who have serious COVID disease continue to be PCR positive for very many weeks. The longest reported is 56 days. Okay. Therefore, it is wrong to assume that the viral load has gone off. It may be, it is not there in the upper respiratory tract, but it seems to be very much there in the lower respiratory tract. Now, with regards to immunity, what Professor Jacob John said is very, very important. There are two arms to the immunity. One is humoral, the other is cellular. Now, in viral infections in general, and in particular in this viral infection, it looks like the cell-mediated immunity is the most important thing for conferring long-term immunity. This is why the antibody tests that are used are not of great value. They may just tell you that you have been exposed to the virus, but they may not tell you whether you are protected. In fact, the British Prime Minister came in for a lot of criticism because he said the antibody test is going to be a game changer, and everybody was after him, and the BMJ wrote a paper saying that he was wrong and the medical journal was correct. Okay, so having antibody positive is not a passport to freedom from personal protective equipment. Please bear that in mind. Now, how do we know cell-mediated immunity is important? from Sweden, where they looked at cell-mediated immunity in this disease, not only in infected people, but also in asymptomatic people who were PCR positive, and also in family contacts who actually were PCR negative family contact, PCR positive asymptomatic people, and people who had infection and who had recovered. In all groups, there was remarkable T cell activation, all right, indicative of immunity developing in them. This piece of information is very, very useful for us because we may have a lot of people who have been exposed to small doses of virus who have actually become immune. That's a good thing. That's a very good thing. It may not be reflected in the zero prevalence studies that are being done now. Zero prevalence studies give you some indication. But if you look at cell-mediated responses, you may find that a large proportion of people in India already have this, which is a good thing, okay? So we need to wait and see how this pans out. This is an article from Sweden, from the Karolinska Institute. Can we go on to the next?
Okay, next. With so many pathogenic mechanisms being proposed from thrombosis to bacterial activation to cytokine storm, what is your opinion on pathophysiology?
It is actually very confusing, isn't it? The pathophysiology of the disease is confusing in some ways. Now, in viral infections, initially the body reacts and you have a fever and so on and so forth, and most people recover from that, particularly youngsters. Now, in some people, elderly and vulnerable, and even in some young people, you get this situation of a marked inflammatory response in all the organ systems where the virus can go. It seems to affect the lung, the liver, the kidney, vasculature. So there is a widespread systemic inflammatory response. They call SIRS, Systemic Inflammatory Response Syndrome. Any person who is familiar with infections is familiar with this term. And the end result of the systemic inflammatory response syndrome is a DIC, sepsis syndrome, shock, and culminating in death, right? Now, this is what you are seeing in this disease. To dissect out the individual components of this is rather difficult, but people have tried to address this syndrome by treating the individual components. They give anticoagulation to prevent thrombosis, for instance, okay? So you treat and corticosteroids to suppress inflammation. In fact, the remarkable benefit shown by the British by using a 10-day course of dexamethasone stands testimony to the fact that if you suppress the inflammatory response, you may be able to reduce mortality, okay? So the inflammatory component of the syndrome, which occurs, say, by around the 3rd week after infection, seems to be well handled by a short course of corticosteroids. And that seems to work in reducing mortality. So the inflammatory response may be actually immune mediated. The immunological mechanism can be an antigen-antibody complex, and antigen-antibody complexes of a particular size tend to get trapped in blood vessels all over the body and set up an inflammatory response. That's the best I can come to in terms of pathophysiology. So one other aspect of pathophysiology you need to understand, which is becoming clear now, that is the hypoxia, okay? Now, everybody has been wondering why people develop such severe hypoxia, but the lung compliance is reasonable. The lung is not too stiff. So this has been a puzzling piece in this mystery of the lung problem in SARS-CoV-2 infection, in the COVID pneumonia. Now, the British Journal of Anesthesia now carries an article where they have looked at high altitude training. Now, you can simulate an environment of high altitude. As you all know, high altitude oxygen saturation, oxygen partial pressure is low. So when the partial pressure of oxygen is gradually lowered, the normal subject tends to compensate by breathing fast. And when you breathe fast, you breathe out carbon dioxide. So PCO2 is very low. So what happens in these people is that the low PCO2 shifts your oxygen dissociation curve to the left. Therefore, the hemoglobin grabs more oxygen. If you do a pulse saturation, you find reasonably good looking values. But please remember that the saturation of 94 or 95 is occurring in a person who is breathing fast and his PCO2 may be 20 or 25. Now, the same individual, if the respiratory muscles become tired because of long overbreathing, then the respiratory effort will become less and PCO2 will quickly build up. And when PCO2 quickly builds up, your oxygen dissociation curve will shift to the right and your saturation will suddenly and precipitously drop. Now, this is the closest explanation that I have found in connection with the hypoxia of COVID-19 syndrome. So it looks like you need to be very, very careful with the hypoxia and have a low threshold for administering oxygen. Okay. So what they are saying is, even if the saturation is somewhere hovering between, say, close to 90 at that level, you start giving oxygen. Okay. You don't wait for the saturation to drop to, say, 85 to give oxygen. All right.
I have one more doubt. Among the steroids between the dexamethasone and methylprednisolone, which is preferable, sir? Because dexamethasone has CNS penetration good, and methylprednisolone has pulmonary vascular penetration good.
Yeah, true. Actually, you have to look at what was used in the British trial. Okay. In the British trial, what was used for dexamethasone, 6 milligrams a day for 10 days, either parenteral or oral. Okay. Now, if dexamethasone reduced mortality to that extent, 25%, I would use dexamethasone because there is proof of the fact that it works in a randomized controlled clinical trial. Okay. Now, prednisolone or methylprednisolone may actually work as well, but in terms of anti-inflammatory potency, dexamethasone and betamethasone are 40 times that of hydrocortisone. If you go back to your basic pharmacology, the dexamethasone, betamethasone, the anti-inflammatory effect is 40 times that of hydrocortisone, whereas methylprednisolone is only 5 times. So, to achieve the same effect, you may have to use a much larger dose of methylprednisolone and you may face certain unpleasant side effects. All right. So that may be the reason why the British went for dexamethasone, because it's a potent agent for reducing edema and inflammation. It's only a short course, it doesn't matter. Okay, 10 days.
Okay.
Can I add something to that?
Yeah, sir, sure.
Yes, sir.
Steroids have an immunosuppressive effect, and it is least so in dexamethasone, I understand.
Yes, that is very true. Yeah, the immunosuppressive effects are much more with prednisolone, which is why if you look at all transplant recipients, they are all on prednisolone, right? Dexamethasone is ideally suited for suppression of inflammation in the very short term. Okay, somebody who got a brain edema due to encephalitis. Okay, that kind of situation, clinicians always prefer dexamethasone because of its anti-inflammatory potency, and also because, as Professor Jacob said, it is it's a very good drug to use in that kind of situation. The immunosuppression is not as much as with prednisolone.
Since the mid-peak of an epidemic or pandemic, which is when 50% of the susceptible population is infected, when the spread will start coming down. With our population of 1.2 billion and we are not having even 6 lakhs affected population, when do you expect to see the peaking of pandemic?
I don't know whether you read our paper on predicting the peak. Have you read that? We'll send you a copy. Now, the only reliable numbers with this epidemic that you are seeing in all these platforms, the only reliable number, this was told to me by Professor Jacob John, the only thing you can trust is the mortality. Because there's no doubt that these people died, and there's no doubt they died because of COVID, because their PCRs were positive, right? The only reliable figures are mortality. So using mortality figures, you can back calculate to look at what would be the number of people from whom so many died, if you know the mortality rate. We did that. And then you also know what is the doubling time. Professor Jacob John told you about it earlier. For one case to become two, two to become four, four to become 8, what is the time taken? And at that point in time, it was about 10 days. Using these two very simple parameters, we estimated that the peak would occur by around mid-July. Now, it is going to be around, in the first week of July.
Yeah.
And as you see in urban India, the rapid acceleration of the epidemic. This happens before the peak. Now we have information that zero prevalence in the urban areas may be hitting something like 30-40% now. Okay, so that is about the time when it will start coming down. But please remember, we are only talking about urban peak. Okay, the peak will probably happen by around July, later July, or even first week of August. But don't forget, the rural areas, it is just beginning. Like the towns, the small villages, only just beginning. So you may see either another peak, or you may see a very broad shoulder on the descending limb of the epidemic peak. So Dr. Jacob John and I discussed this many times, and yeah, he is of the opinion that there may not be another peak, but a rather prolonged descent of the descending curve. The ascending curve, limb of the curve will be very sharp, descending limb will be a little gradual. And in between, you will get spurts of cases. As and when every new village gets infected, you may find spurts of cases. All right?
Then one more
Can
question.
can I add to that?
Yes.
Yeah, sir.
Yes,
Yeah,
yes.
sure, sir, sure.
There is a question on herd immunity, and I will combine the two.
Yes.
Herd immunity is actually the proportion of immune people in the population. And you hear about 60-70%, and 60-70% is called the herd immunity threshold when the epidemic cannot survive. It will be low endemicity at that level. But you don't have to reach that point to get the peak. The peak is half of that. So if you think 60% is the immunity threshold, when you have reached 30%, the curve has two limbs. Think of a bell-shaped symmetrical curve. So half of the people are infected before the peak, and the other half after the peak. So approximately, I don't think even 30 will be necessary to reach the peak, but 30 is a good guess. When you reach about that level, our infection would peak. Okay.
I would add to what Professor Jacob John said. I hear that in Dharavi, you are all aware of Dharavi, the Mumbai slum. In Dharavi now, you get only occasional cases. That means Dharavi, that pocket has achieved herd immunity. There are only occasional cases now. They're not the big numbers that are coming in. All right. And the same kind of thing will happen in all the big cities. And that I think will happen soon. But there will be a slower descent because of the rural spread. And that is what we need to be very, very cautious about, because our healthcare facilities in rural areas are not as good as in urban areas. And we can't afford to have our rural population, large numbers dying. I think that will be catastrophic.
So next is CBC and acute phase reactions in asymptomatic and atypical COVID patients and possibility of false negative in PCR.
Okay, the first one I will take. I am aware only of publications which are compared moderate versus severe COVID in terms of the acute phase reactions. Now, interestingly, the two things that are very different between moderate and severe COVID. One is the patients with severe COVID have very low CD4 cell count, a particular type of lymphocyte, and they have a very marked increase in D dimer, which is a reflection of widespread small vessel thrombosis. Okay, so D dimer increase, low CD4 cell count seem to be the hallmark of severe COVID. Now, asymptomatic and atypical COVID patients, the inflammatory markers tend to be low, but I'm not aware of a study that has particularly looked at it. Okay, they would tend to be low, but whether it will be significantly different from the moderate COVID, I will not be able to answer that. The second part is possibility of false negative in PCR. Professor Jacob John and I just published an article which I am sure all of you would have read. This was in the newspaper. Both false positives and false negatives do occur with PCR. And we had given an example of a false positive there, which you can read. The false negatives are more disturbing. That is, if you take a throat swab and send it for a PCR, it picks up only about 40% of those who are infected. If you send a nasopharyngeal swab, which is preferred, it picks up about 70% of cases. So 30% are missed. Now, why does this matter? It matters a great deal in treating patients. Suppose you have a patient who comes with a pneumonia. He has a low count, right? And he has other clinical features that make you think he may have COVID. You do a PCR and PCR comes back as negative. If you don't treat him as COVID pneumonia, it will be equivalent to medical negligence because the patient may actually have COVID-19 because the test can be false negative. All right. So the idea is not to miss out any patient with COVID pneumonia. For that reason, undue reliance on PCR testing can be dangerous. All right. Similarly, if you do PCR in asymptomatic people, so let us say family contact, family of 5, you have 1 infected person, there are other 4 exposed, you pick up 1 patient as being PCR positive. Does that mean that the other 2 have not been infected? The answer is no. They may very well be infected. You do not know. You will know only if you also concurrently do an IgM antibody by a reliable assay, or later if you do IgG antibodies or look at cell-mediated immunity and the T cell changes in the other letters. So in a virus that can spread as fast, it's a very catchy virus, the SARS-CoV-2 can spread fast. If you find a negative report in an asymptomatic contact, that does not mean he is not infected. He may actually continue to infect other people. So these are the pitfalls of PCR testing that we have pointed out in that newspaper article, came in the Hindu. Okay, it says PCR testing a double-edged sword. The good, but also it has problems.
Always with the clinical. And I like to add one more question along with that, sir. In few COVID patients with the mild symptoms, only IL-6 is interleukin-6 alone is elevated. Other investigations are normal. Saturation is normal too. What can we do for such cases? When should we repeat interleukin 6, whether is needed, and your experience about this?
See, these asymptomatic and minimally symptomatic people, the only thing you need to do for them, and I am sure Professor Jacob John will agree with me, is strict home isolation so that they don't spread the disease. Okay? And in about 2 weeks' time, most of them will stop shedding the virus, about 80%. If you make it 3 weeks, 99% will stop shedding the virus. So there is no need to repeat any test if they are clinically well. Okay. Remember, they are asymptomatic individuals. So why do we want to do tests on them? And the tests are not going to make any meaningful difference to your management. Now, on the same note, I'll ask you a question. If it is an asymptomatic patient who is positive on a PCR contact of a patient, PCR positive, asymptomatic, should you give him hydroxychloroquine? What do you think?
Actually, only
Now, no, yeah, actually you can look at it two ways. Actually, only the French did this. That is, they did viral cultures in patients on hydroxychloroquine repeatedly during the course of treatment with hydroxychloroquine.
Sir, sorry to interrupt,
And
sir. Actually,
yeah,
Jacob Jan, sir, want to attend a meeting at 8 o'clock. I think he's getting a bit
okay,
late. So I'll just,
okay,
thanks, Jacob Jan. Thank you, sir, for participating.
thank you, sir.
Thank you, sir.
yeah,
I think Vijay sir can continue, sir. I think only Jacob
yeah.
Jan, sir, will take a leave.
I would like to express my very sincere thanks to Professor Jacob John for keeping me very busy for the last 3 months and for having been a mentor, which he always was. Thank you, sir.
Thank you, sir. Thank you for it, sir. Thank you. Yes, sir, you can continue, sir.
Next,
Okay.
next question. How long does the IgG antibody last after an infection, and does it provide immunity against secondary infection? And almost the herd immunity already discussed by sir.
Yeah, see, against the second infection, first you have to ask yourself, is there any reported, documented case of a second infection? The answer is no. There is no single case proved by virus culture of a reinfection in a patient who has recovered from SARS-CoV-2. If it is published, then it will receive very worldwide attention. I have not seen one. What people have shown is, I told you earlier, patients who are severe COVID pneumonia, after discharge, you keep on doing PCR from the nasopharyngeal swab. The swab may become negative, say after 3 weeks. It may become positive again by 5th week or 6th week. It's the nature of PCR. Okay, that means what is coming out is viral RNA, right? PCR testing, you are checking only viral RNA. You are not checking whole virus. Okay. Now, when people have tried doing cultures on such patients, that have been done only on limited numbers, they were done in the United States and also in South Korea. In a limited number of patients, they found that by about 2 weeks, the viral cultures become negative, even though the PCR is positive. So the inference is, after 2 weeks, infectivity may not be there, but they are not 100% sure. They are saying, we did only a few patients, so we are not very sure. So you continue to be cautious. Okay. PCR positivity can last up to 2 months in a seriously ill COVID patient who recovered. That does not mean that the person is infected. It may not mean that the patient is infective, but you have to be very cautious and make sure that that person doesn't spread disease, right? IgG antibody after infection, nobody knows what is the duration for which antibody will be there. If you look at the natural history of IgG antibodies after any infection, the average duration for which they last is about 3 to 6 months. So in about 3 to 6 months, the antibody levels will come down. That does not mean that you are at risk for infection. if your T cell immunity has already been boosted by the previous infection. All right. So more would depend upon what your T cell immunity is than on the antibody level. T cells carry a memory. They have an immunologic memory, and in response to another exposure to the same virus, there will be a very brisk antibody response. Herd immunity already covered.
Yes. The role of Fabiflu in COVID-19 mild to moderate infection.
I'll confess I do not know the answer because I have not seen any trials with this drug. I do know it has been being marketed in India, and there may be theoretical grounds on which it is marketed, but clinical experience with the drug is limited, and I do not know whether it will work. If it is to be used, I think it is good to use it as one of the drugs. If you are going to use it, what are you using it for in mild to moderate cases? See, mild to moderate cases, they will recover on their own steam, correct? Now, if you are using an antiviral drug there, you should use it for reducing the period of infectivity. That means you don't want them to spread it to others. That's the reason you would use antiviral drugs there. That's why I asked you that question before. HCQ was somebody who is asymptomatic but PCR positive. The French have shown that the duration of viral shedding reduced from 2 weeks to 1 week after HCQ. For that reason, if there is no contraindication to HCQ, it may be worth using it in people who are asymptomatic but PCR positive. Okay? I would think the same kind of thing would be true with Fabiflu, provided it works. For you to say it works, you should administer the drug and follow up viral cultures, not PCR, viral cultures. And that very few laboratories do. All right?
So, can a rheumatoid arthritis be considered a risk factor for severe COVID complications? Whether any alterations in the medication should be done to prevent them from acquiring COVID-19 infection? Does methotrexate be stopped if they develop COVID-19?
See, in a stable patient with rheumatoid arthritis on methotrexate, when the patient develops a COVID infection, because of immunosuppression, this patient is at higher risk for developing a serious COVID disease. So it would be appropriate to discontinue methotrexate temporarily and maybe adjust the other drugs that you are giving for rheumatoid arthritis, in particular HCQ, okay, so that you are able to prevent an exacerbation of rheumatoid arthritis, right? Now, if the patient develops COVID pneumonia, anyway, according to the present guidelines of treatment, the patient will probably receive dexamethasone. That will keep the rheumatoid arthritis at bay, right?
Yes.
Now, once the patient has recovered from the COVID pneumonia, and once the dexamethasone is stopped, that is where the question comes. Do you restart this patient on methotrexate or not? That's a difficult one. Okay, you would try to manage with the minimum amount of immunosuppression possible to keep the disease under control. Okay, you may not restart methotrexate. Believe me, I've had patients not with COVID, but with other serious infections, say cryptococcal meningitis, methotrexate for psoriatic arthritis. Now that patient nearly died, right? And he recovered from a serious infection. We had to withdraw methotrexate. And we managed him without methotrexate, and he is still doing well. So you have to look at alternative forms of treatment which are safe and at the same time effective. And there are many.
Steroid play a major role in the treatment of severe COVID-19 infection. Does that mean a
Yeah,
patient
Dr. Raja made a comment. I'm sure you saw that. Dr. Raja made a comment, rheumatologist. He said, yes, methotrexate should be stopped. You can use citalopram sulfasalazine, and hydroxychloroquine for keeping rheumatoid under control. Okay, steroids. Okay, major role in treatment of severe COVID-19 patient. Patient on rheumatoid steroids is protected from COVID-19. I can only guess. My guess will be that this patient, if he develops a COVID infection, will not have the severe inflammatory response that occurs later. He may be partly protected from that. Okay. But if he does become sick, we may have to give much higher dose of dexamethasone in order to get him out of that. But after that, you will just have to continue his previous maintenance dose of corticosteroid. Okay.
Does MMR vaccine in adults protects from acquiring COVID-19 infection? Does the healthcare system in Vellore can manage the upsurge of cases? What is your opinion regarding this, sir?
MMR vaccine, there is no evidence that it protects from acquiring COVID-19 infection. There is no evidence for that. Are you asking this question because children be a little immune?
Less infected.
There is a different reason why children are immune from COVID. There are two things. In children, cell-mediated immune responses are very brisk because their thymus is still active. All right. So they are able to cope with this viral infection far better than adults in whom the thymus has become atrophic. Second, there was a very interesting study on ACE2 receptors in the respiratory epithelium in children versus adults. It showed that ACE2 receptors are far fewer in the respiratory epithelium of children. So there is not much chance of the virus getting in and setting up an infection. That is reduced. All right. Does the healthcare system in Vellore, can it manage the upsurge of cases? I think it should be able to. I think it should be able to using the right kind of measures. I think two things are important for managing this epidemic. One is for preventing disease from spreading, and the second is to reduce mortality. The steps required as public health measures are very simple. Everyone wears a mask, you will reduce spread. If elderly and vulnerable people protect themselves from exposure, it's called reverse quarantine. So they go into a shelter, they follow all the things that you want a COVID-19 infected patient to do. They wear a mask all the time, frequently wash hands, seclude themselves, keep themselves away from even other family members, use a mask even when they are talking with family members. If they are that careful, then the elderly will reduce their chances of getting infected. So there will be no big rush on your ICU beds. There will be no big rush for ventilators, and you will have successful epidemic management. The key elements will be universal mask for preventing spread and cocooning the elderly or sheltering the elderly from getting infected as a method of reducing serious COVID disease.
Please unravel a useful COVID, already we discussed, I think, sir. Vaccines for COVID-19 and your opinion regarding the new vaccine, Covirax, which has started its human trial few days back in India by ICMR.
Yeah, before that, Geeta Lysander has a question. How long are positive patients infective others? Now, generally 2 weeks, it can extend to 3 weeks. Okay. PCR positive patients remain infective for 2 weeks on an average, but it may actually extend to 3 weeks. So, better to self-isolate for 3 weeks. Now, vaccines for COVID-19, I am very proud of the fact that India has been able to actually produce the vaccine. And it has been the untiring effort of the National Institute of Virology to grow the virus, sufficient numbers, share it with a biotech company, and we already have a killed vaccine available. Now, the vaccines, you remember the two issues. One is you are vaccinating people who are healthy, right? People who haven't contracted the infection, who are healthy, are the ones who we are going to vaccinate. So you are giving a drug to a healthy person. Now, the caution has to be ultimate. You don't want to do any harm to this healthy person by giving the vaccine. Now, if you look at experience with other vaccines that were used for respiratory viruses, the respiratory syncytial virus, you'll all know that, pediatricians know that very well. There was a vaccine that was produced against RSV. That was a failure because the vaccine produced more problems than the disease. Similarly, the SARS-1 virus, which is very similar to the SARS-CoV-2 virus, which is causing the current pandemic. The SARS-1 virus, people developed 4 very good vaccines. But these vaccines, even in the animal trial stage, produced a serious problem in the lung when vaccinated animals were exposed deliberately to the virus. So this is called antibody-induced augmentation. All right, this happens in dengue also. If you have dengue, one episode with one strain, you develop antibody. If you have a second episode of dengue with a different strain, you are at risk for developing dengue hemorrhagic fever, right? This is antibody-induced augmentation. Now, most people who in the vaccinology field with SARS-CoV-2 are worried that this kind of thing may happen with a COVID-19 vaccine, which is why I think a lot of caution is required. You must do the studies, but the studies should be with a view to protecting the interest of the study participants. You cannot take any risk with them. So start with a small dose, see how they respond, then do a little higher dose, see how they respond, document every single side effect, and wait. You may have to wait for something like 3 months, 4 months to see whether they develop any side effect. And only if they are safe and sound, then proceed to a controlled clinical trial, which will involve thousands of people, very carefully done over a longer duration. Again, with a view to safety. Please remember, the overall mortality of this disease, overall mortality, is 1%. 100 people get infected, across the board, 1% will die. 99 will survive. Now, if you give the vaccine, and if 2 people die out of 1,000, you increase the mortality by 100-fold. You can't do that. Okay? That's why all the scientific bodies in the country are recommending that we do it very slowly, carefully, methodically, and ethically to prove the efficacy of the vaccine. Okay? Vaccines are a good idea, but we have to be extremely careful.
Now, since the monsoon has started, we will have the surge in the number of fever cases, including scrub typhus and dengue and other viral diseases. And won't it add more difficulty in diagnosing the COVID as the clinical features are less specific?
Yeah, I would agree with that. See, it is going to be difficult. The unique features of the infection, which are used in the revised clinical criteria, will be helpful. All right. That's why we call it ABC major criteria, and you need to have one from each, so that you have a wide number of features for you to call it COVID-19. Okay. So this is undergoing a trial at the correct time in CMC. So the clinical criteria are being evaluated in CMC hospital, and I'll be able to answer that question maybe in about 2 months time or 1 month's time, as and when they finish the study. But my guess is that there are some patients who will fulfill almost all the criteria we have listed for undoubtedly COVID. There'll be some who will fall in the gray zone between COVID and other febrile illnesses. And other febrile illnesses might, like scrub typhus, might stand apart because of the presence of an HR, because of the presence of, you have an ELISA test for scrub typhus. Okay, so it might be possible to distinguish between the other causes of fever by adding a few additional tests and by paying meticulous attention to clinical examination. Okay, so it might be possible to separate them out. And of course, the lab tests will come in handy. Okay, the lab test, please remember, in any infection, a clinical diagnosis is very important. And the lab tests supplement the diagnosis, not the other way around. Not that the lab test makes the diagnosis and clinical evaluation is not relevant. That is never the case. All right?
How long do COVID-19 patients remain? Almost you answered that. And,
Infectious, yeah, I answered that.
Does AC inhibitors and ARB should be changed to calcium channel blockers in case of hypertensive dose or already?
See, this is something that we did for our patients right at the beginning of the epidemic, because there was a Lancet hypothesis saying that, look, if you use these drugs, the number of receptors in the respiratory epithelium may increase, and therefore they may be at risk for developing severe disease. Therefore, we took a decision at that time and we changed, except in patients where these drugs were absolutely indicated. That would include, say, patients with cardiac failure and all that, where the drug is indispensable. So usually hypertension, you can use the calcium channel blocker, right? You don't have to depend entirely on an ACE inhibitor. There is a wide variety of choices. In cardiac failure, choices are limited, right? So in those with only hypertension, we made a decision at Thriumalai Mission Hospital to change. Now, after that, there have been papers that have appeared which seem to indicate that there is no increase in risk on ACE inhibitor. Unfortunately, one of these papers was by the same group of investigators who played a hoax on the medical community by publishing papers without any results. They published in very prestigious journals. This article on ACARB came in the New England Journal of Medicine, and the article was withdrawn. It was withdrawn because the researchers were not honest. They were dishonest. So please remember, all these things take time. If you look at hydroxychloroquine, it has been going up and down like the yo-yo. Initially they say it's good, then they say it is bad, then they say it doesn't work, now they say it works. Well, it takes time for medical opinion to firm up. And in the setting of an epidemic, there will be chaos. Therefore, you have to think for yourself and decide. So we made a decision, Thriumalai Mission Hospital, that we will not use these drugs except where it is indispensable. And we stick by that stand for the time being until the ground is clear.
The indication of remdesivir, tocilizumab, and plasma therapy in COVID-19 patients when you use this, and role of anticoagulants already we discussed the last session.
As you all know, remdesivir is working on the basic pathogenesis of the disease. It acts on the reverse transcriptase enzyme, okay, which Dr. Jacob John spoke about. RNA virus. So if you block the reverse transcriptase, then it can't act on the cell DNA and replicate, right? So that is the reason for using this drug. You know who made this drug? Remdesivir. Go and look up. I believe it was an Indian. And his name was Ram Desikan. And so the name is incorporated in the drug, even though they spelled it wrong. Okay, now this drug is one drug which has shown promise in the treatment of antiviral drug that has shown promise in COVID-19. And it is still undergoing a clinical trial. It is being used on compassionate grounds in many countries in patients who are becoming sick and there is no other alternative. So that is where its place is. The monoclonal antibody, I'm not very sure. I'm not very sure at all. The ground is very, very slippery there. I would rather wait for more information. Plasma therapy, convalescent plasma therapy in COVID-19, we wrote about it. It is a good idea. You have a patient who is rapidly deteriorating, and you are facing a situation where you may go on a ventilator and may actually die. That is a kind of patient where convalescent plasma containing IgG antibody may help to reduce the viral load. National Institute of Virology, Pune, has shown that convalescent plasma, when added to viral cultures in vitro, actually inhibit growth. In fact, they have developed an assay, functional assay for the antibody, which is called the neutralizing antibody. So you get the patient serum, you add it to virus culture, and if the antibody there neutralizes the virus, prevents viral growth, then you say the patient has neutralizing antibody. So convalescent plasma has been demonstrated to have neutralizing antibody. Number two, one control trial of control clinical trial of convalescent plasma published by the Chinese, where they showed that people who are on the threshold of being ventilated, not already on ventilator, you find increasing requirement for oxygen, you are just wondering, am I going to ventilate or not? That kind of patient, given convalescent plasma, there was a significant benefit. And what was very important that study was they studied the viral load in the blood. There was viremia. The viral load in the blood came down to almost negligible in 3 days after convalescent plasma. So these are reasons why convalescent plasma is likely to be useful in this disease, at least in patients who are on the verge of being ventilated. You don't want to use it too early because there are risks associated with convalescent plasma use. You can have a reaction after administration, which is immunologic, which may confuse the clinical picture. Second, it doesn't work in people who are in the advanced stage of their disease already on ventilator. It doesn't work there. So in that intermediate group where they are on the threshold of being ventilated, timing is very important. Convalescent plasma may be life-saving. Steroids we already discussed. Anticoagulants.
Yeah, discussed.
Yeah, steroids we discussed already. Dexamethasone 6 milligram once a day, 10 days. That's a standard British protocol. I think that's what is widely followed everywhere. Anticoagulant, useful. Useful in patients who show this severe inflammatory response syndrome that I alluded to and who are going to be on ventilator. Because anyway, you require anticoagulation to prevent DVT in these people. Incidentally, it might be beneficial in terms of the coagulopathy that actually occurs in these patients. There's a pro-thrombotic tendency in these patients, as you're all aware. There are patients who come in with stroke. There are people who come with myocardial infarction. There are people who come with myocardial. So the wide variety of both macrovascular and microvascular events occur in these patients. In that setting, anticoagulants are considered to be useful. Even though it is primarily used for preventing DVT and pulmonary embolism, it may be incidentally beneficial for their tendency to thrombose.
Then
Is that the last question?
Last question, yeah. When do you feel this will end and your advice to doctors during these challenging times?
It's a question that, see, you must ask an astrologer, all right? Now, scientifically speaking, looking at what we have before us, I think it will become substantially less by the beginning of the new year. by say 2021, January, February, is when it will come to that low ebb. And it will continue at that low ebb, okay, with intermittent spurts after that, all right? So people all over the world are predicting that the whole thing will probably end late 2021. Even these small spurts of cases may end by end of 2000. So we are in for a long innings with this virus. Now, maybe another year and 3 months, all right? But substantial reduction by the beginning of the year. New year, I think, will start showing very few cases. And doctors need to actually, all healthcare professionals, doctors, nurses, technicians, everybody, they have to change the way they have been practicing all along. See, there is a saying, physician, heal thyself. You're all probably aware of that. This is the time that physicians need to protect and heal themselves. Okay, it's very important. You have to protect yourself, because if you don't protect yourself, if you fall sick, you no longer are very useful to the community, right? So please protect yourself. And all these personal protective measures are here to stay till well into the next year. Okay, so equip yourself with sufficient protective equipment to keep free of this infection. That's what I would tell the doctor. And number three, when you are dealing with patients, we have to tell them the truth. It's very important to tell them the truth. Okay, be very truthful. If a patient has a COVID infection, you tell him, yes, you have got this virus. Yes, you have got to protect your family. Yes, these are the things that will help. And give them very realistic figures. Be reassuring, be optimistic. If, for instance, even a 65-year-old, if he develops a COVID pneumonia, a 95% chance that he will come out of it, right? So emphasize the 95% and not the 5%. You get what I mean? So you remain optimistic and you infuse optimism into your patients. That's what I would advise. All right.
Thanks, sir. It's the last question. Thanks for your extensive and patient enough to answer each and every question, sir.
Thank you. I enjoyed the interactive session. Thank you very much. All right.
Last quote is not offensive. Avoid touching men to stop the spread of COVID-19, like men, mouth, eye, and nose. And follow men to prevent the COVID-19. Wash your hands with the soap and obey the social distancing, and masks to be used properly and exercise regularly. Never ignore above 4 lines. Thank you, sir.
Nice one. Good one. Good one. Okay.
Sir, one.
Thank you.
Sir, hello. Sir, one small doubt regarding the criteria which you have made.
Yeah.
Sir, actually the criteria is depends upon the area in which you are. If you are in Chennai, you have even a 1-day fever with 2 persons in the same family having similar illness, you are more chances of having COVID. If you are in a small village where there are no cases reported and you are having 3 days fever, then you may follow this criteria. If you are in a very high prevalent areas like Chennai or Mumbai, then your criteria might have to be in what about in those areas, sir?
Fully agree, because any disease, the prevalence of the disease in the population is called the pre-test probability. Supposing in Chennai, the probability of a person with fever having COVID is 50%. I think it is about 50% now. Pre-test probability is 50%. Okay. So 1 out of every 2 patients who has fever is likely to have COVID, right? So in that situation, you don't need to fulfill all the criteria for a diagnosis. I fully agree with you. It depends on prevalence. So where the prevalence is low, these were written up for rural areas in India, please remember. They're not written for urban areas which have lab facilities, which have a lot of medical centers and so on. And this was written up for rural areas, okay? And there, these criteria still.
Yes, thank you very much, sir. Sir, even in our Vellore district, this I think two persons with in the same family having a history of fever. I have seen some 2-3 families. They have one day history with all the family members affecting. They have joint pain or fever. Only that, no cough, no breathlessness, the respiratory rate is normal, but they turned out to be COVID positive. So I believe that 2 or 3 members in the same family getting affected in even in our district in this situation, I think it is more clinically there are more chances of COVID. Even though
I agree with you there. Familial clustering is another important factor too, because as physicians we all take family history, and so you will get that information there. And in the present climate, if one family member has fever for more than 3 days and the cough, the government authorities will anyway come and check. Am I right? Isn't that happening? They are actually checking on everyone with influenza-like illness, ILI, right? So I think even in say second-tier cities like Vellore, uh, yes, they will be picked up. And if one member is picked up, the other family members who have fever obviously have the same disease, okay, because of familial clustering. But your difficulties will come once the monsoon sets in, right? That when you are going, somebody pointed it out, you are going to have other febrile illnesses coming, and they are going to make this differentiation between the two febrile illnesses a little more challenging, and you might perhaps find the clinical criteria useful in that setting, particularly the radiological criteria. I think radiological criteria, you have good evidence, right? A lot of studies where only about 60% of patients with COVID-19 have a positive PCR. The other, there's a picked up basically on imaging. The imaging characteristics are so typical that a combination of imaging and PCR testing is held to be the best current diagnostic test.
Thank you very much, sir. And regarding the universal masking, use of either 3-layer mask or cloth mask, I think with the current degree of prevalence, the entire public is wearing mask. But the problem is they are involuntarily they bring down the mask when they want to try to speak. They say that they are getting suffocated. I think they have to get them more educated that you have to wear mask, especially when you speak. They come to our consulting room and just involuntarily they remove the mask and then they try to speak. That I think there is enough advertisement regarding how to wear mask, but you should not remove that or pull it down when you try to speak. That is much more important, I feel.
Very, very important. And a lot of people have a mask hanging around their neck.
Yes.
Okay.
Most of them wear it around their
they carry it around the neck. And when they see somebody, they'll lift it up. When they want to talk to somebody, they'll pull it down. Now, these are things that you should tell them is not in their best interest. See, people have to understand. Anybody who understands will follow this. Now, if you don't educate people, but if you blindly say everybody wear a mask, everybody will agitate, right? Because they'll say, why should I wear a mask? Okay. We face the situation with the patients and families all the time. But you have to spend time educating them. It is in your interest, in the interest of your family members. Once they understand, they do follow. And of course, if there is nobody within sight, supposing you are walking, and there is no other human being in sight, right? And if you are feeling uncomfortable, if you lower the mask for a couple of minutes, it's not going to do you harm, all right? But the minute you see another human being, a few feet away, then you have to pull up your mask. Okay.
I have a question. Sir, can stethoscope? I have a question.
Yeah.
Can stethoscope be used by physician at this pandemic? If so, how to use? One of the members asked in the chat.
Okay. I think the best way I have seen is people who have a thin polythene curtain kind of thing. Okay. Patient is on the other side, doctor is on this side. The stent, it does not come in contact with the patient's chest. but only through the thin plastic sheet. Okay. Now you can put your you can use a small polythene bag, okay, around your set and then put it on, then discard the polythene bag. Well, if I do that, now the government will be after me for using disposable polythene. Okay, so I have to be careful about that, but that's one practical way of using it. Okay.
Then one more is, since the prevalence of COVID-19 has increased, it's time to stop testing and making clinical diagnosis and focus on treatment. Can I repeat, sir?
No. You can hear a plural rub. Yeah, you'll remember. Remember, you may find a number of physical findings on chest examination. Okay, clinical examination of chest, you may find clefts. You may find what sounds like a plural rub. Those things are likely to happen. Are we done?
Yeah, sir. Actually,
Yes, sir.
I think we have a number of questions which have been flooded in the phone. I think
Yeah.
it will take time. It will take even more than 5 hours to discuss all the questions.
If you actually
Right.
send me the questions in writing, I will answer them to the best of my ability and then send it back to you. You circulate it. Okay. All right.
Yeah, definitely. We'll put it all the questions API things.
Yeah.
Yes. And thank you a lot, sir, for spending your valuable time and answering all the questions for more than 2 hours. And I request Dr. Srinivasan to deliver the vote of thanks. Dr. Srinivasan.
Yes. Yeah, good evening, sir. Thank you, Dr. Jacob John and Dr. Seshadri for an excellent presentation to enlighten us with your knowledge. And it is very useful for all of us in dealing with COVID, sir. Thank you for your patience in addressing all the questions and answers. And information website was very useful. Thank you very much for your session to both, sir. Thank you.
I would like to thank all the people who attended the session for making it very interesting for me by asking very challenging questions. I always like to teach students this way. They ask questions and I answer to the extent I can. And when I don't know the answer, I say I don't know. And I go and look up. That's the way I learn. Thank you.
Thanks a lot, sir.
Thanks.
And
thank you.